just make sure I can make this work. As Lee said, I'm Lisa Charles, and I actually trained with Lee at Harvard UCLA, and I'm really grateful for him inviting St Lucia to this meeting. It's a real privilege to present at such a prestigious conference, and I'm very excited I'm presenting our journey in St Lucia because I do think of myself as relatively young, and I thought, my God, what am I going to present that nobody else can question me on or know better than me? And certainly my journey through emergency medicine at home is something that is my experience, and therefore I can claim it without too much fear. So let's get started. So this must be a pointer as well. So where are we? St Lucia is a small island in the Caribbean, and there we are. Cuba, just to orient you, is up here, and here we are in Havana. So St Lucia is quite south, just above Venezuela. We're about 265 square miles with a population of about 160,000, so we're relatively small. I did some research on the net, looking to see what I could find about emergency medicine in developing countries, and I think the article that hit home, or hit closest to home, was this article from the World Health Organization from 2002. And it really highlighted that the challenges I faced when I came back to St. Lucia in 1999 were similar to what most developing countries face as far as emergency medicine. And the quote, I think, captures exactly how I felt. The provision of timely treatment during life-threatening emergencies is just not a priority for health systems in developing countries. It's a funding issue, and it seems that it's a challenge that everyone faces. And global health policy, the focus, and even today, 13 years later, global health policy even in St. Lucia is still focused on maternal and child health, especially infectious diseases, and you find very little emphasis on emergency care. However, we all know that timely treatment of emergencies can mitigate some of the conditions that contribute to the burden of disease that you see in low and middle income countries. And so what we found happened in St. Lucia is that communities began to establish that they really expected good emergency care, and they started to put pressure on the politicians to start to put funding into emergency care, not just their primary health care system. And it was driven by the communities and eventually by the politicians. Fortunately, most people come to St. Lucia for our beautiful beaches, and we are the #1 honeymoon destination in the Caribbean and have been for several years, and not for our health care. So this is where I joined the journey, 1998, 1999. And again in 1998, almost 14 years ago, that was a pivotal year for emergency medicine in St. Lucia. We had several high-profile deaths that thrust the emergency room, or the accident and emergency department as we call it in St. Lucia, into the media. And I think once the newspapers started calling for the heads of the general manager, the politicians knew they were next in line. And so in 1998, fortunately for me, because I came the very next year, the politicians put $1.5 million into revamping the emergency room in our one public hospital. So this is Victoria Hospital where I work, and it pretty much, this was in 1998, it pretty much looks the same. The emergency room is actually off down to the right, and funny enough, to go up to admit patients up into the hospital, we have to actually take patients out into the open, and that exists today. So when it's raining, everybody stays in the emergency room until the sun comes out, which is one of our problems. So I joined the journey in November of 1999, and at that time we had the one public hospital, Victoria Hospital. The catchment area at that time was about 110,000, and we had about 23,000 annual visits, with an admission rate of about 7,000 per annum as well. The accident and emergency department at that time was just one big open room, and there were just 7 beds, there were no monitors, and there was a trauma area which sounds good, but really it was a place where you could bring the really bloody patients so that the kids didn't have to see you sewing up chalk wounds, etc. So it was just a room that had a swinging door to keep away the blood and the gore. And it was just really just this one big open room. There were only 4 doctors and 11 nurses providing a 24-hour service. And traditionally, the emergency room was the place where you sent the doctors who were not getting along with any of the consultants in the main hospital. It was really the dumping ground. And so you can imagine the 4 physicians down there were not the easiest to work with. So if we skip ahead 14 years later to now, September 2013, we still have only one public hospital in the north, Victoria Hospital. Our catchment has grown as the population has grown, so we serve about 135,000 people. We have an annual visit about 36,000, so that's up by about a third. And the annual admissions are up a little bit to 8,000. Now we have a total of 4 monitored beds, 8 unmonitored beds. We have a gynecology bed in a separate room, so there's some privacy when you see your female patients. We have a 5-chair asthma bay, and we've actually divvied up the space into treatment areas. So we have a triage area. We have an urgent care area now that is separate from the main ER so that you don't mix your category 1 patients with your category 5 patients. We do now have a radiology suite, which is really just one portable x-ray machine in a room, but we at least have x-ray, because as you see, to roll up the hill, so to admit somebody, you need to roll them up the hill. To get an x-ray, you need to roll them up the hill. So everything stops when it rains, and we are living in the tropics. So I'm glad we have a radiology suite in the ER now. And we've just a little more than doubled the staff. We now have 9 doctors, not including myself, 25 nurses and 1 technician. This is the city, Castries, and VH is sort of down here in this corner. If we could just back up a couple of yards here, Victoria Hospital is kind of sitting right in this corner. It just shows you some of our catchment area. The north of the area is the most heavily populated after the Castries City Basin. And so this is why we have more than 3/4 of the population using that one public hospital. There is another hospital in the south that's part private, part public. So the rest of my slides, I'm just going to discuss a little about what were those things that I did when I first came in 1999 that stuck. And so the interventions that went a long way really and truly are just the ones that are still there now. So what I put in place in 1999 that's still around, I think that those are the successes. If they weren't going to be successful, or if they weren't successful, they went away. And it's not rocket science. The things that worked were things that were cost effective, things that were sustainable, things that had a broad application. Big impact. Big impact was very important across the board. The staff had to be convinced that what they were doing made a difference. The patients had to feel that what we were doing made a difference, and the government, who was paying my salary and keeping the salary of all the new physicians and nurses and funding the ER, needed to see that we were making a difference. So there was really a big political mandate to make a big impact with that $1.5 million. It had to be, the interventions had to be not labor intensive. So we didn't have a lot of staff, so whatever we were going to implement needed to be something that could be done without a whole lot of staff. It couldn't be skill intensive, not that we didn't have skills, but skills match labor. If you don't have a lot of labor, you're not going to have a lot of skill at your fingertips. And it couldn't be equipment dependent. Again, going back to the cost. And I found that things that did no harm, minimal complications, also stuck around. And that would be for obvious reasons we'll talk about in a little while. So I just divided those interventions into about 4 categories. And the first one that I'll talk about is the organization of the ER, not organizationally, but organization of the ER. And when I arrived in 1999, there was no triage. There were just long wooden benches, and you got seen as you came, literally. And of course, that contributed tremendously to the mortality and morbidity, the high mortality and morbidity rate we saw in the emergency room. So one of the very first things we put in place was a simple triage. And I'm not talking about ESI or anything fancy. I'm talking about if you're over 70 years old, you came right in. If you had chest pain, you came right in. If you had belly pain, you came right in. Just trying to make it as simple as possible, because we just had to figure out with minimal time how to get patients that were the sickest into the emergency room. One of the things that I did right up front as well were to divvy up the emergency room. It was not working. It was extremely inefficient to have everybody in that one space. So we had to cordon off an area for triage, cordon off an area for procedures, cordon off an area for resuscitation that wasn't just a bed with swinging doors. Delegation of roles and getting the appropriate number of staff is also important. We had very little staff, so we had to make sure we maximized every nurse and every physician on duty. And one of the things we did with delegation of roles, we had to expand our roles, the roles of the nurses. So if my nurses, and today, even today with 23 nurses, they all suture, they all IMD, they all put NG tubes, all put catheters, all do IVs, they do our ECGs. If we did not have that support as physicians, there's no way we could make that ER function. Training, I spoke about triage. Most of you think of when we talk about the Caribbean, you think about laid back, no fuss, no rush, and that's absolutely true. One of the hardest things it was to do when I got to St. Lucia was convince the nurses and doctors that there was such a thing as emergency. I mean, people would come in and there was never any rush. There was no sense of urgency to anything. And no matter how much I said, how much I jumped around, they just didn't get it. So what I ended up doing was, actually I'll tell you a story. I remember I came on November 9th, and on November 11th I got my first call for a multiple trauma at 2 in the morning, and I drove in, and there were literally 3 men on trolleys, and they were all dying at the same time. These are 3 young, healthy men, really bad motor vehicle accident, and everybody was just standing around, and I couldn't understand what was going on. I'd only been there for 3 days. I walk in, they're just about their duties, and these 3 men are literally gasping, agonal respirations. So I checked out the first 2 that I ran into, because at this point I'm triaging as well, and they literally stopped breathing while I was intervening. And I went to the last one, and he was still very bloody faced. I still remember very bloody faced. And I said to the nurse, can I have barely gasping and frothing? I said, can I have an intubation tray? And he just stopped and he looked at me. I said, can I have an intubation tray? And nobody did anything. I said, do you know what a laryngoscope is? And he brought it in the Welch Allen case, and the batteries were in one place, and the handle was there, and so I had to now stick the batteries in, and of course this guy loses his pulse in the interim. So I said to him, start CPR, and he's looking at me. I said, start CPR, and he's looking at me, and I said, start CPR. And one of the nurses pulled me to the side, and another nurse said, we don't know what CPR is. And I had just finished at UCLA. I had done ACLS. I had been, big resuscitation hospital. And I'm standing there with these 3 young men and this 3rd guy who's dying. And I literally couldn't do anything because I can't do CPR, intubate, put the IV, get the drugs, order the blood. I can't do it all. Fortunately, I got this gentleman intubated. I got somebody to start, and I literally said, just press on the chest. And he actually went up to the OR, but he died in the OR. I don't think he had sustainable injuries. But it was such a life lesson for me. And at that point in time, I wanted to get on the next plane and go back to LA and say, forget this is not going to happen. But what I did instead is I started to teach the basics of resuscitation. So we started with BLS, and then we started then we moved on to ACLS and PALS. And the whole idea is when you start to teach a culture of resuscitation, they do speed up because they get into it in a more systematic way. And I'm really grateful to ACLS, PALS, BLS for that, because it does teach that sense of urgency that comes with resuscitation. So that was an important thing to get out there, get them learning how to do chest compressions, etc. We spoke about the expanded nursing duties. And again, like I said, my nurses suture. They don't suture always to my standard, but we can't, and that's the other lesson you have to learn. You cannot do things to the standard you're used to. You've got to find a standard that's in between that's good for the patients. Clinical care protocols for common things that kill quickly, that was also a really important training intervention. You cannot write clinical care protocols for everything, but you can write clinical care protocols for those 10 or so things that you don't have time to teach while they're happening. So a severe asthmatic comes in, you know, it's written out. The doses are written out. So you can just say refer to the protocol because you are one person, and in this period where you're exponentially teaching everybody, you've got to have some help. And I thought that the protocols were quite helpful at that. This is, these are what we call the pitons, and they're two volcanic caps that jut out of the sea. So, and this is the village of Soufrière that is nestled between the pitons. We were just nominated, or we just got nominated for this to be the 8th wonder of the world. You know, every time I drive down to Soufrière, it is so magnificent to see. There's no picture that you can take out of a book or take off the internet to really capture how amazing the pitons look. But this is a St Lucian, you know, a St Lucian wonder, at least, even if we don't become the 8th wonder of the world. I don't know, if you stop and think about 5 or 10 medications that if you were traveling away for 6 months to work in a remote country that you'd carry with you, that's how I felt when I walked into the ER, because there was barely anything. There was ampicillin, there were Panadol, there was Gravol, and so I had to suddenly say to myself, well, what medications do I need to incorporate? There was literally just that. There was some Septrin as well. And again, these are the medications that stuck. So if you go into the ER today, you will find all these medications. Even though I tried to introduce 20 more. Again, it had to be cost effective. It had to be not very skill dependent. It could not be equipment dependent. So I remember nitride. When I first coming out of UCLA, everyone was using nitride for hypertension. I thought, oh God, we've got to get nitride down here. And so we got the first 5 bottles, cost me more than I want to disclose. I can think of a lot of other things we could have used the money for. But then you needed an IV pump, which we didn't have. And then you needed an art line, which we certainly didn't have the skills to put in a monitor. We didn't have the art line adapters to put on the monitors, etc. So, you know, no matter what, nitride wasn't going to work. It just was too complex of a drug to introduce. So you end up with the basics. Ceftriaxone is still a staple in our ER. We don't have imipenem and all those other things. Ceftriaxone is still a big gun, and when we pull it out, it's still a big gun. IV nitroglycerin, I think, is magical. I think IV nitro treats everything. I mean, it's great for CCF, it's great for unstable angina, it's great for your it's just great. It's great for the hypertensive emergencies, and that's what you start to learn. You don't have to have the nitride. You don't have to have every class of drug. You really come down to those things that are cheap, that, you know, most of your nurses can use and use safely, and that work. IV digoxin. You know, one of the things I learned as well, being in St Lucia, you know, I came from UCLA again, and everything was time dependent. So you had a 60-year-old in AFib, I was giving this example earlier, and their heart rate is 170, and you're taught they're going to infarct. You've got to slow that down as quickly as possible. Slow it down, or else they're going to infarct. You're going to end up in a quarter blow. And I came here, and we didn't have anything to slow down AFib, and nobody was dying, nobody was infarcting. They eventually slowed down on their own, or you gave them oral digoxin because we didn't have IV, and they slowed down 3 hours later. But people were just dropping dead, and I was convinced if you didn't slow them down right away, they were going to infarct and die. And what you learn in the Caribbean, because you have no choice, is just to slow down. You've got to slow down. It's okay. They can tack away at 170. I know it doesn't look good to have a 65, 70-year-old tacking away at 170, but generally they don't infarct, and generally they don't just drop dead. At least not on my shift so far. So we got IV digoxin because diltiazem, which I did bring in, was extremely expensive. and we just couldn't sustain it. And verapamil, you use it and you turn your back and the nurse opens it too wide, and suddenly the patient's in CCF and their blood pressure. So you just have to go with what is safe and what most nurses can use and what is cheap. And let me tell you, ivdigoxin, okay, so it takes 45 minutes to kick in, but nobody's going to die, trust me. Same thing with CCF. The number of people that we would intubate, in fact, I did intubate. My wake-up call for ventilation is, and I've never forgotten this thing, I almost referred it to the coroners to go to court. It was a 45-year-old, very obese lady who came with CCF. And she was adenoid respiration, she wasn't responsive. So this is about, again, days into my starting, and I intubate her. And so after I've intubated, I'm proud of myself, I came in, I've done it. And so I said, well, bring the ventilator. And they said, bring the what? I said, bring the ventilator. And they said, what ventilator? There are 2 ventilators and they're in the operating theater, they don't move. So I thought, well, who is going to ventilate this lady? And they said, well, call her family in. And I said, you're kidding. And they did. They called her family in, and the nurse, because it's a nurse in me, said, okay, this is what you do. You squeeze it and you let it go. And I'm standing there going, my God. You know? So, of course, following up on this lady, they move her up to the ward, and I come the next day, and the very first thing I do is try to find out, well, how did this lady do? They said, she died. And I said, she died, but she was turning around, And they said, yes, she started breathing on her own, so we stopped bagging her. I said, you stopped bagging her? They said, yes. And we left the tube in just in case. So they left this lady on the ward. She had started to make some respirations, and they stopped bagging her. And here comes another challenge, because there were so many layers to the challenge. You can get your ICU up to par. You can get your ER up to par, but where are you moving these patients that you're tubing, that you're strepping? You've got to now look at the hospital and see what you can do to improve the rest. That was one of the big problems. As soon as I got monitors in the ER, okay, so you give your streptokinase, you've taken care of your MI, but you don't have an ICU to move them to. And so you've got to fix several layers within the hospital. Almost done. Equipment. We've just started ultrasound in the last year. We don't have a CT scanner. We didn't have one when I came. We still don't. I never thought I could learn to practice medicine without a CT scanner. And here I am 13 years later, still practicing, I think, relatively decent emergency medicine without a CT scanner. I never know whether it's hemorrhagic or ischemic, so nobody gets aspirin, nobody gets TPA, and they all tend to eventually recover. So what are you going to do? Okay, but we do everything else. We don't go after their blood pressure. We do everything that we can do, we do. But if you don't have a CT scanner, there's only so much you can do when somebody comes with a clear stroke. AEDs and bag valve masks. Forget the intubation tray. Let's start with the basics. You can't bag them to start with. Minor surgery equipment. I'll tell you another quick story, and I got my 5-minute mark. Must have been about 2 weeks. Again, everything happened in November. I walked into a bay, and I saw one of the 4 doctors had just finished sewing up this 13-year-old girl who had gotten slashed on the face in a bottle fight. And he had used 2O silk. And I looked at him and I said, are you nuts? This huge scar, young girl, beautiful girl, with this huge scar and 6 big fat black 2O silk sutures in her face. And I thought, this defies all reason. I said, take those out right now. So he takes them out. And I said, now go get the nylon sutures. And he said, what nylon sutures? So I had to have him re-sew this young girl's face with 2O silk. I know, it's terrible. But it just goes to show you. So again, on my list, in that first month, the things that I had to keep writing down on the list is what to bring in. But again, things like nylon sutures weren't there, and that's so important. So that was high up on the list, and that's still there now. We do use the normal sutures. We haven't gotten to 6O on the face, but at least they use 5O. And testing diagnostics. ECG, we had no ECG machine. Pulse oximetry, point-of-care testing, and the radiology unit. These are the Diamond Falls. Let's spend long on there. Okay, last set of slides. A couple things. What you think you'll miss, but you don't. I absolutely do not miss trauma surgeons. I hope there's no trauma surgeons in here, but I miss people. Oh, are you a trauma surgeon? I'm sorry.
He's one of the good guys.
Okay. The only thing I learned from trauma surgeons at UCLA was to swab the axilla when you're doing a chest tube. I don't know who goes through the axilla to do a chest tube. I know I don't, but I remember Klein going off on swabbing the axilla. I still don't swab the axilla. You know what? I'm going to be on 3 antibiotics anyways. Why am I swabbing the axilla? Don't tell me. I do not miss having 5 options for every drug. I am so glad I don't have to explain to some consultant somewhere why I chose labetalol over metoprolol over propranolol. I don't know. We only have propranolol in the drawer, so that's what I use. I'm very thrilled about that. I don't miss 10th generation cephalosporins. I don't know if you all are there yet, but I'm glad I don't have to learn 5 generations of cephalosporins and all those other antibiotics. We have ceftriaxone. We have ceftaz if you're really bad off, because it covers Pseudomonas, and that's where it is. So I don't miss central lines and arterial lines. I thought I'd miss central lines, but we don't. We hardly have an indication where you must put a central line in. I told you why I don't miss NIFI, and I don't miss resuscitating everyone. It is so good to go up to an elderly patient and go to their family and say, look at your mom, I don't think she would have wanted this, and not have to worry about a DNR order or legal implications. So that's really great as well. What you really do miss, I really do miss second opinions. I really do miss discussing cases with colleagues. I miss backup. I miss knowing that there's no ENT surgeon, there's no anesthesiologist. I do miss having the backup, and you do miss diagnostics. I do miss the CT scan every now and then, and our radiology machine goes down all the time, and sometimes we have to, well, now I know we can use ultrasound to look for fractures. A well-stocked blood bank, we rarely have blood, and that's always a source of stress, because you never know when you're going to need it, and we often have an empty blood bank. And I miss replacement everything, defibrillator pads, speculums, suture sets. It's just, it would be lovely to have a smooth flow of these things, and we don't always have them. I did miss St Lucia Carnival, but I am now back and jumping, so. And I think 2 more slides. What I knew I'd miss, what you knew you wouldn't miss and you definitely don't, lawyers. I don't miss practicing defensive medicine. I really love doing the right thing. I really love not having to cover every single base just so that somebody can say, 10 years down the road, well, you didn't think of this. I don't miss having to CT scan the belly for an appendicitis. I can still send an appendicitis to the operating room with a physical exam. That's great. I don't miss narcotic-seeking behavior either, putting central lines in people who have, used up every vessel. Okay, last slide, future challenges. I know you mentioned them, we didn't discuss, but my first future challenge is collecting the empirical evidence to validate the role of emergency medicine and its contribution to improving health in St. Lucia. I really would love feedback at some point as to what kind of evidence we need to collect so that I can say to the government, please keep investing money in the ER. This is a good thing. Cost justification and resource utilization in the face of increasing violent crime. It is difficult even for me as an emergency medicine. And it's a small community, so you get your friends calling up. I had a friend who, some guy broke into his house, and he shoots this guy, and he calls me in the ER to tell me I better not resuscitate this guy because, he was in my house, and I have kids. He was coming after my kids, and you're sitting there going on the phone, damn, I may have 4 units of O negative blood, and I've got to pump them all into this bugger, and it's a small society, you feel that way. You feel like there could be a pregnant woman come in next that really needs the blood, and you've got to pour a bunch of resources into not victims of violence, but perpetrators of violent crime. And that's hard in a resource-limited setting. it's very tough now adapting to this changing disease profile. It was really easy just to treat pneumonia and AGE. It's very difficult to treat the complications of diabetes and hypertension. Extremely costly. Dialysis is sinking our health system. We only have 11 dialysis chairs, and they take more money than any other department in the hospital. And literally, we have only 11 times 3, about 33 patients up north on dialysis. So that's difficult as well. And then public education on accessing emergency care. Now that we've become more reputable, we have more people using our services inappropriately, and we're getting swamped in the ER as a result. And that's it. I'm sorry I went over, I'm sure. So this is our national flag, and I would really love that you all visit St Lucia. We have a very good emergency room that will take good care of you if anything happens.
Does anyone have any questions for Lisa?
Lisa, thank you so much. Now, I'm probably the second non-ED physician here. I'm a pediatric intensivist. I work in Sydney, and your talk is great. Absolutely fantastic. Now, part of the question really that I have is children who need critical services were quite protected, particularly in Australia, and I know in America and the UK. The question that I have for you is, how do your critical patients, pediatric patients, where do they go? The idea of having a 65-year-old woman breathing on a tube on the ward just broke my heart.
So we've come a long way. I gave the 13-year time lapse for ER, but we now have a 3-bed ICU. And we do have ventilators in the ICU for each bed. So we do have 3 ventilated beds, or 3 beds that we can use ventilate, and they go to that ICU. We have, because pediatrics pulls everybody's heartstrings, we have a lot of support for pediatrics from Toronto, from Cincinnati, a couple other children's hospitals. So we get to fly out a lot of our critical children. There are a lot of programs that will take them. But they go into the ICU and they get less than optimal care because we don't have an intensivist, but at least there is the option now to ventilate and take care of. We had a dengue epidemic about a year ago, and our only death was a pediatric child, and I think part of that was not having the ability to take care of, because she needed proper intensive care, and we just couldn't deliver that level. So it's still a challenge, but it's better.
Anybody else? Questions?
That was wonderful. That was very real life, kind of gets you because you realize what's really happening on a global level. So I just applaud everything you've done, and I'm very proud. I wanted to ask you if albuterol was on your medication list.
Yeah. Albuterol was there when I got there. So those were medications I added, but I should have said yes. So we had the basic, but we did add Atrovent, and I'm still not convinced that, because Atrovent's expensive, and I still am not convinced whether Atrovent tips anybody over who's already on albuterol. So those are the things that we look at. I did include Atrovent. We do have it regularly, but yes, albuterol is there.
Okay, great.
And prednisone and hydrochloric.
Ketamine?
No ketamine.
Oh.
Thank you. That was such a wonderful talk. I noticed that your staffing pretty much doubled in the years that you've been there. How did you go about recruiting these extra staff members?
Cuba. Thank God for Cuba. About 3/4 of our staff currently at Victoria Hospital now are Cuban scholars. There was an MOU between the government of St. Lucia and Cuba. Unfortunately, that MOU is sort of running out now. It's much less. But they were taking somewhere between 10 and 15 nationals, St. Lucian nationals, to Cuba every year and educating them for free. And that is how Cuba has literally held up our health system. And if you walk in, the two doctors, if I can just introduce very quickly, Dr. Emmanuel and Dr. Imab, trained in Cuba, and they're 2 of our physicians from home that we sponsored to come down. So yes, Cuba.
Along those lines, I went to visit Lisa soon after she started in the department over there, and I can attest to everything that she says. It's a absolutely beautiful country, and I'm sure, I know that she would support anybody who's interested in coming and working over with her in the department. She's moved on. I think you're now the CMO.
I'm the medical director at the hospital, unfortunately, but this is only to transition us to a new national hospital. I intend to go back to clinical care as soon as possible.
So if anybody is interested, Lisa's going to be here through Friday, so we're going to have a chat with her about.
Did you say you needed?
As many as would come.
You just recruited a whole room full.
Just real briefly, I mean, in the day of Skype, it doesn't make any sense that anybody feels like they don't have a second opinion or an ability to QI or what have you. And it's something that would be relatively easy, I think, for a bunch of us to find a way to put together and really help out our colleagues abroad.
Yeah.
Whether it be rural areas or whether in the States or Australia, or whether it be St. Lucia. Shouldn't make a difference.
Certainly as a pediatric scarce facility where you don't have pediatric, advice, pediatric intensivists, I mean, time difference, it doesn't matter. Just call us. Absolutely.
You guys are jumping the gun, because I think Peter's going to address these exact topics in his talk after John's next and then Peter. So Peter's talks on using the iPhone for basically emerging technologies, including telemedicine. I think is one of the portions of his lecture. So just stay tuned, and hopefully they'll answer some of those questions.
Before we move on, I brought two Peacock Frosty Bear mugs, one for Lee and one for Mark from St. Lucia. We're very hospitable. We drink lots of, and our national bear is Peacock Bear after our Peacock. But Lee has also organized to have Matt Dawson, Mike Mallon come down to do an ultrasound course, all free, because we do not have the money to fund programs like this. And I mean, I cannot say enough as to even just inviting us up and supporting two colleagues to come up. I mean, really tremendous stuff to think of a very tiny island. Thank you.
Okay, next is John McKenzie's back up again. So I'm not sure if he has another fairy tale for us or something of similar ilk. He's going to be speaking on an online curriculum or online training for students. Here's John.